second here, and we're recording.
Great. Okay, so welcome to our second breakout room, everyone. Thanks for being patient as we get all this sorted out. Let me see, there's a couple chats. I'm gonna make sure I'm not missing anything. So we are talking today about the qualitative assessment exercise. And I just want to remind everybody what it looks like. So just a second, I'll share my screen. So hopefully you have it in front of you. Where am I? It looks like this, just to make sure you're kind of aware of it. Everybody looked at it. I know we've had there have been a couple questions about what we're doing. So I just want to make sure you have it before I go into our spiel here. And I'm going to ask Shane to chime in with me when he wants to add anything. So I think, as I said earlier, it's been a while since we've seen this criteria. We did a lot to get to really distilling this back at the February meeting. And it was really an articulation of the priorities that our work group wanted to see. And we wanted a model that would be capable of delivering these priorities. So for many of these, yeah.
Nora, there's just something on the top that said everyone exit your breakout room and return to room 1. I don't know if that was a mistake or. Okay,
let me text New York Liz really quick. Shane, do you want to do this while I figure out what's going on? Do you have the facilitator, Jenna, in front of you?
I can get it. My computer crashed right before we started and I don't have everything pulled out.
I think we're probably fine.
Okay.
Okay, I'm just gonna wait and see if she says anything to me. Okay, so for many of the criteria, we might not be able to answer the question because it really will depend a lot on how we implement the model. And as Jamie said earlier, this is really important input because the legislature is looking to us to not just recommend the model, but to identify key priorities where that need to be addressed in implementation. For example, some of the things we were talking about earlier, I think someone at the end made a really good comment about, well, if we did cost sharing, it would need to be done this way. And there's a lot of rules and regulations and conversation that happen as that implementation takes place. And somebody else I was talking to recently reminded me of, there's often many work groups that would be developed as part of an implementation of such a program. So the work will not end with the recommendation about the model itself. So really the focus of what we want to do is articulate our desired outcomes and help try to shape the structure and provide insights based on our individual experiences. And also, I think, really to just identify areas where we want to know more or where we think we need to know more about this. And, as Jamie described earlier, we will take that back and come to you. But right now we have a list of 34 separate qualitative criteria, and that's just a lot. And there may not always be the data that we need to answer all those questions, but we really want to have a conversation going back to what we talked about months ago. So I think that's just the prelude to this. And I just want to, make sure that everybody is, clear on that. Kelly, I know you asked some questions about it earlier. Is there anything else you want to say before we get into our discussion?
It looks like Kelly has a process question.
Yes. I just wanted to know if we could quickly rate each of the bullet points.
Sure. Well, so
especially that access bucket is really big.
It's really long, right?
Right.
So yeah. So let me tell you my questions that we have prepared.
Okay.
And if it doesn't go do what you want, you guys, we can be flexible. So let me just read them off to you. I just wanted to make sure that we're all on the same page here. So for the 6 categories and the associated criterions, which of the models best support this criterion? Why is that, or why not? Now let's talk about the criteria and I think maybe we should just talk about question 2. in terms of things that people would want in any system, which of these criteria would you recommend be included no matter what system is implemented and why? So I think that we should start with question number 2, Kelly, because I think that's what you're asking. So let's look at the giant list and talk about the ones that are, no matter what system we pick, it's really important that the system address this issue. So that would be the first question. So should I pull it up again for you guys to see?
Yeah.
Okay, let me do
Oh.
that.
I see.
Okay, you probably did this on your own, but I'm going to pull it up and we can just go through. So we'll go through each bucket. And Shane, you're taking notes, right?
Yes.
Okay, great. Okay, so for governance, oh, actually, I'm on the wrong page. Okay, here we go. So for access, which is our giant list, which of these things are the ones that, no matter what system we have, are important that we pull out?
Do you want us to just do like a thumbs up or something?
Sure. So seamless coverage from birth to death. Is that what access means to you? Okay, I'm seeing thumbs up. Excuse me. Anybody else want to say something about that? Okay. Provides access to comprehensive, essential, effective, and appropriate healthcare services. You guys can use your reactions or feel free to pipe up.
Oh, right. Cool.
Oh, I can hear you. Yep. Is anybody's hand raised, Sean?
No one's hands raised. I just have a thumbs up vote from Mr. Kovar.
Great. And Sean, you're recording, right? Great.
I am
Okay.
recording.
Cool. Provides a full range of services, whole body holistic health services. Not that important to folks. I mean,
no, I think it's probably important to most people, but that opens the door to every conceivable practitioner as approved to participate in the plan. And without getting into any details, that will create huge amounts of friction.
Provides coverage for experimental treatments for rare diseases. Okay. See some thumbs up there. Yep. Allows the choice of a healthcare provider. Yeah. Okay. Choice is really important when we talk about access. Okay. Make sure I expand my window here so I can see everybody's face. Provides access to culturally attuned care. Okay. And for this one in particular, I just, this one along with equity, I think there are some things that really are implementation questions. So we may not be able to have hard data on saying this model or that model will do X, Y, or Z in terms of improving equity, but we can say, we know that the way contracts are written could actually make a big difference here. Okay, so provides equitable access based on a person's need, and regardless of income, geography, age, gender, etc. Okay. Allows for easy navigation of the healthcare system for patients and providers. Okay. Provides access to affordable care. So when we talk about access, is that the main thing that we're talking about? Okay. Promotes preventive health care and utilization of primary care.
Sorry, Liz.
Yeah.
I get a little hung up on that. Provides access to affordable care because, like, I have access to the Lamborghini shop to buy a Lamborghini, but it doesn't really help me buy a car. I just want the health care and I want it to be affordable. The word access kind of.
So access and affordability are not the same thing.
Exactly.
Exactly. Okay. And when we look at our buckets, we have access, quality and equity, administration, and feasibility.
Oh, wait, this could be like rural access.
Well, it could be. No, it could be. But I think your point is a really important one, Kelly, because I'm just looking at this going up and down. I want to make sure. I mean, I should know this by heart now, but when we talk about, we don't have a bucket for affordability.
I thought there was one small bullet, but I was thinking, gosh, it should be its own category. It's so huge.
Well, it is that bullet. It's provides access to affordable care. So
Yeah.
So it's not its own bucket.
Right. I wish it were.
Well, that's an important point for us to think about. Because I think there's been some conflation of access and affordability. And just because you have access doesn't mean you actually can afford the care, which is
that's exactly what I'm trying to say.
Which is part of the reason we're having this conversation. Okay, so that's noted, definitely. And that's when I'm going to actually point to Pam and Joan here, because I know they're actually doing some work on this. And another work group, that's a part of our, the whole idea of cascade care and fill in the gaps, that there are some ways to address affordability, and some work is going on. So we're going to hear from them at some point. So.
Liz, Kelly also had a question around can she have some more clarification on what culturally attuned care? So I don't know if someone would like to.
Long-term.
So not right now. You don't need that explanation right now.
I don't need it right now, but long-term,
Okay.
I think we do. Like, what are we? To be very crass, what is the investment? What does that mean? Like, what are you?
Okay. So Shane, when we're going through this and talking about what matters, if you could also put a note, like group would like to know more about what this means. Yeah. Promotes, we already did that. Oh yeah, promotes preventive health. We were talking about this, preventive health and utilization of primary care. Promotes workforce capacity building. Do we think this is part of access, or these things we think are part of access?
Provider workforce?
Yeah.
Not insurance company workforce.
Yeah, just that there are providers available when you try to go access care. This is that issue that you were talking about, the rural issue, Kelly. This is something that would be an issue there.
Yes.
Okay. Facilitates the right care at the right time in the right setting. Okay. Provides psychiatric care in the least restrictive environment necessary. And I mean, that's very specific, but I also think you can back out of it a little bit and talk about access to behavioral health in general, behavioral health providers. Okay, Kelly, I see your hand is raised. Sean, can you unmute Kelly? Or she's unmuted. Go ahead.
I just recently went through this with a friend, and I guess my takeaway from it is just the quality of care. Like, it seemed like the cure was as traumatic as the actual, the treatment was traumatic as much as, there's just so much to unpack with that. For example, like, does that mean we're going to just throw people that are in have desperate medical illness conditions back to their families to take care of without support? I don't really know what that means. There's a lot to unpack with that one.
Right. I think, I don't think it just means, from my understanding of what it means being able to be treated in the community when you can. Again, like, I think a way to think about this comment, and I don't remember back in February who actually made this comment, but I think you could almost look at this as behavioral health in general, because getting behavioral health services for a lot of people is very challenging. Not to mention the fact that it's often when somebody's put in an institution. So I think that is, go ahead.
I think you just changed the term to behavioral health. The psychiatric's just too loaded.
Yeah. Okay, can we note that, Shane? And I think that this is another area, Kelly, where there's a lot of ongoing work that we could probably bring forward to talk about that's going on in our state, particularly around this issue, and especially right now.
Yes, I know it's a high priority for the state.
Okay,
And
so,
Patrick has his hand. Oh, sorry.
oh, go ahead, Patrick. I hear you, your hand's up.
Yes,
Oh.
it was. Trying to play by the rules. On this bullet point about psychiatric care, I mean, I don't think anybody would object to changing to behavioral health, whatever, because it's, I think, applicable as much for physical health, behavioral health, but you could just as easily put dental care in here, or, I mean, fill in the blank of the type of care you need. I'm not sure that this one really helps to fine tune what we're looking for in a system, or how we should design a system. And to me, this one sort of falls back into the question of facilitating the right care, regardless of whether it's physical, mental, dental, vision, at the right time in the right setting. So we seem to be, I think, kind of spending more time on something like this than the larger discussion about how do we build it, how do we pay for it, how do we make sure that it has equity of accessibility, and how do, the financial model obviously is going to address the affordable part, because I think Kelly was right in her comment that just because I can go to, she say, a Lamborghini dealership, doesn't mean I can afford to drive home in one of those vehicles. So, a little more time sussing out some of that detail, I think, is more important than some of these sort of redundant or derivative kinds of topics.
Okay, thank you. It's good to see your face too. I didn't see you sharing your screen earlier, so thank you. I think, is there another hand up? Sean, do you see any more hands?
No more hands.
Okay, so I think what I'm hearing, and Shane chime in here, is that when we're talking about access, we're really talking about access to affordable care that a person chooses, where they could choose their provider, where they are, where they can get the right care at the right time, even if they're in a rural community. And in terms of things like, and people want to know more about what is culturally attuned care. There's interest in knowing more about behavioral health. Going up here again. And it's comprehensive coverage. I think, Patrick, what you're saying is, rather than getting into the weeds on something like, psychiatric care, behavioral health, or oral health, we're talking about comprehensive care, whole person care. Okay.
Yes.
Rich.
I see Dr. Kovar's hand is raised
Just
again.
the other, after hearing Patrick say that, I really agree. If you look through all these categories, all the buckets, there's no calling out of any specific type of service except in that one place. That doesn't make sense. Finally, the general term.
Okay. Okay, so let's go on to our next bucket, criteria that we, when we were talking about things that matter to us, these were the things that, well, I guess what I do want to just take a quick pass and ask, does anybody have any opinions on whether or not, which of these three systems would help achieve what we're calling access the best? Just since we went through the details there, does anybody have a sense of it? Go, Dr. Kovar.
Yeah, I mean, I think option B, probably because they're so involved in all the networks that exist already. They've created their own networks. They've worked out their contracts. May not like the terms in the deals, but they've worked out geographic penetration. The state would have to recreate everything unless we figure out a way to involve a limited number of plans. The state calls the shots and people can bid for it. It seems like it would meet these, even though, it's not really what a lot of people would like to think of as a single payer, but it's the most realistic and expedient to achieve these access goals. If you just try to close the gap, you have to build an enormous ancillary infrastructure to try to do that.
Okay, that's really helpful. Okay, I see Patrick again.
I agree. Dr. Kovar's presented it well, and I think that if we're giving a number score to it, that option A and B both probably are a 1 or a 1.5. The option C, fill in the gaps, is probably a 3. It might do some good to help get us more access writ large, but probably not as effectively as either of the other two options.
Okay, that's great. That's really helpful. Any other comments before we move on? And I do want to say again, we will come back to this after we get more from the actuaries around the actual models and where we have more data, but this has actually been really helpful. And I hope it's making more sense to me as you guys talk. So Thank you.
I just want to say, I don't know. So Kelly is adding to the discussion via the chat feature, and I don't think that that actually records. And so
We can try to capture it, but Kelly, why don't you, Kelly, can you just pipe up real quick?
Sorry. Yes. Oh, I'm
Yeah.
sorry. I tried to be helpful and move the conversation
Oh,
along.
no, it's okay.
I just was agreeing with Patrick that it was good to not get in the weeds of this very specific issue, medical issues people have. And I prefer option 1, and certainly I don't see option C helping.
Okay.
Yeah.
Okay, great. I think we can probably capture the chat, but I'm not positive.
You can download a chat. I'm pretty sure.
I know with my Zoom I can. This is a
Oh.
larger Zoom, so it's not mine, so I don't know all the ins and outs of it. So I'm sorry. Okay, governance. So this was another area, and here are the things that we identified, that you identified as areas, that criteria around whether or not a model would meet the mark. It ensures transparency and accountability in how it's governed. Participation by community-based systems organizations is included in its governance. Respects the primacy of the patient-provider relationship. Ensures administrative accountability. Tribal sovereignty and voice are maintained in its governance. The patient will have a voice in how the healthcare system works. So, reactions. I'm changing our way we're doing it because we need to go faster before we get kicked out of here. Dr. Kovar.
Similar to Patrick's other comment, I think these are just splitting hairs between, basically, it could be one bullet. It could be consumer and delivery system representation, plus minus the payer.
Okay.
So I think we could not get caught up in the weeds on this one. And I just would point out that this whole conversation of tribal sovereignty doesn't necessarily need to be represented in this process, because it may be a freestanding and separate entity when the dust settles.
Okay. Is there anything in here in particular you want to know more about? Kelly, go ahead.
I was just going to say, I think that where it comes up is, and I shouldn't speak because I'm not fully an expert on this, but on the urban Indian situation where it's not tribal in that healthcare situation. Do you know what I'm talking about? Most Native Americans do not live on tribal land anymore, so they don't have access to tribal healthcare, is my understanding.
Yeah, I mean, that's very helpful.
Okay. So anything else on governance here? Anything we want to know more about?
But if we're ranking them, I'd say again, C is probably the least effective for a change in governance structure, where A is probably a 1, B is probably a 2, in my opinion.
Okay.
Agree.
Thumbs up. Other opinions? Pam or Joan, any thoughts? I'm grouping you together since you work together. And I know that's a big part of your work is doing a lot of transparency and governance work.
Well, I think that any of the models can meet these criteria. It doesn't, I don't know, I'm not saying which one is the best, but you can require a fill in the gaps to do these things. In fact, you know, we've made a lot of progress on these areas, fill in the gaps.
Okay.
And you can have a universal coverage model that doesn't do these things well. It's your intention when you build the model and what your requirements are.
So when we talk about this as a priority for the work group, we want to be as clear as possible that the model has to do X, Y, and Z and implement the various processes we know. And so perhaps what we maybe want to come back with more on are and I don't know if it's within the purview of this work group, but it potentially in an implementation work group, it would be a subgroup that focuses on making sure there's transparency and governance is, meets these requirements. Kelly. Go ahead, Kelly.
Pam really got me thinking, because I mean, you can have a system that's run according to the rules that it's set up, but it still isn't democratic in its governance. Does that make sense? Like, as an exchange member, I don't really feel like I have lots of feedback for the exchange, but I don't feel like there's an easy way for me to provide that feedback. Does that make sense? And I'm sure it's allowed, but it's more than just having the rules that it's actually implementing true accessibility.
We maybe modify the bullet that was recommended by Dr. Kovar to say authentic consumer and delivery system representation.
Yes, thank you. Well said.
So again, we think, and I mean, I think it's true that any system could do this. We have some opinions about which would do it better than others, but we want a system that, a model that basically has the language that you just said, Shane. I'm not typing as I'm writing, so I'm counting on you to capture it. Okay,
And
so go ahead. I hear
just
somebody trying to pipe up.
As we're ranking the forms, option C really couldn't do anything except have its own, say, freestanding governance entity that would not interact, and it just wouldn't go well.
Right. So, I mean, from my perspective, the thing about C is that you would have multiple systems potentially with different ways of doing that.
Right.
So, so that's when, you know, you could have the same thing across all three different systems, but it's still three different systems. So, okay. So let's move on to quality and equity. So I'm going to just read off the things that the group identified before, and then we can, you know, nitpick or change, and then talk about where we want to know more, and then rank them. Incentivizes or enhances the delivery of quality healthcare. Includes efforts to improve healthcare safety and minimize medical errors. Encourages transparency of healthcare quality, including reporting of adverse events. Encourages consistency in healthcare delivery in rural areas and across different cultural, ethnic, language, and other types of communities. So what do folks think about this?
I would say that these are certainly goals of any system, but I would also say that each of the options more or less are equally suited to being able to deliver on these particular bullet points.
I was thinking that the unified nature of option A and B makes it easier to do it and more cost efficient to do it than option C.
You know, on the quality and equity, you have, you know, your financial incentives are going to make a big difference in how easy it is to do these things. And so the financial incentives in a universal coverage system are probably more aligned to do quality and transparency. That was my problem with the governance, is you don't have the same incentives in governance to, you know, I think that's what I did not say well when we were talking about that section. So you don't have financial incentives that align with the system on governance issues. So you have to have requirements that make your system do that.
Right.
Quality, you know, some of those things come along naturally just because you don't have a profit motive to do things that are lower quality or just to do them.
I'm actually looking at this and, you know, seeing we have the one bullet on consistency in healthcare delivery, and I'm thinking I'm going to talk to our project team about this, because we have that other one up top about culturally relevant care, and if we're talking about equity, is that a separate category of its own? It's just something to think about, or does that fit under here? Because I know there's been a lot of attention on that. So. And I appreciate your points, Pam and Kelly, about it seems like it's probably easier to achieve this in one system because you're able to control more of it at the same time. So anything?
I think that might have been the opposite thing, but that's
oh, okay.
We
Sorry.
just hit the 5-minute warning.
Okay, thanks, Sean.
Yep.
Okay, I'm counting on Shane to capture the notes. So I was backwards there. Okay, so administration and feasibility. Let's move along here. This is a big one. So, and I think what I think Jamie said earlier, and you know, there are some of these things where we can get some data, and there are some things where we can't. For example, like administrative costs. So administration and feasibility, this was a really big category that folks identified as a priority. reduces administrative costs, includes mechanisms to reduce duplication of services, includes effective cost controls for all services, including prescription drugs, amenable to value-based payments to providers and healthcare systems, implementation changes due to federal regulations. These are things, this is whether or not it's, wait, hold on, there's something missing here. Feasibility, that's a feasibility, yep. And there's a number of them here. Impacts of program implementation and administration on key delivery system stakeholders. Supports administrative simplification. So this is a lot of that detail, which is, you know, so when we're thinking about these, what are things that people, A, want to know more about, and B, things that don't sit well, and then we can talk about ranking them. So which of these criterion are really important to you? Go ahead, Kelly, is that you?
I don't know how the actuarial folks are gonna deal with us. It just seems so.
Is the question how we're going to model the administrative efficiencies?
Yes.
Yeah, so I can give you we just have a couple of minutes here. I'll give you super high level. We are essentially looking at differences across different models in high level administrative costs, and we'll probably bring a range with our assumptions about how things could look in Washington back to the group to get your feedback, and then we'll finalize within that set.
Okay.
Similarly with the administrative efficiencies on the provider side. So go from evidence-based, share our assumptions with the work group, get some validation, and then build that into the final model.
Oh, okay, we have 2 minutes.
I have one thing.
Please, go ahead.
You have administration and feasibility together, and I think those are two really different things. That when you start looking at your feasibility, it's like you're kind of running into the brick wall of reality.
Yeah.
And I think it would be good for everybody just to pull those things out and have those ranked separately, and then look at admin issues, which, you know, there's distinct advantages of admin under a universal access, universal coverage. And I think it's fair to rate those things that way for the people who support that system, and then look at the feasibility separately.
Great
Richard
point.
has his hand up too.
Go ahead, Dr. Kovar.
Yeah, oops, let's see, sorry.
Oh, what happened to you? You muted.
You're mute there, Dr. Kovar.
You're
We're
mute.
trying to, okay, you need to unmute yourself.
Sorry,
Oh,
my
there-
eyes fell
okay.
on the open enrollment period issue after listening to the video, where really we're not looking at open enrollment if this is paid for by taxes. You live here, you're in. So I don't know if that confuses things, but it certainly directs one towards one plan or another.
I appreciate what Pam said about feasibility and administration, because I think, you know, I was struggling there a little bit because of the words around when federal changes happen, like, or what's happening in the federal environment. That impacts feasibility, but is it something we can cost out versus the administration of the program? That's kind of a different thing that we're looking at. Any thoughts on, you know, which of these models would more likely, you know, first let's do it, which one is most feasible in your opinion?
Option C is probably the most feasible, but it doesn't necessarily address or include some of the goals under administration, like value-based payments, reducing duplication, reducing administrative costs, and so forth.
It's the most expensive.
Yeah, because of the administration. Okay, and what about feasibility? I'm sorry, I just said that. What administrate? Okay, go ahead. I'm getting myself confused here.
I think the feasibility question are bigger impediments to options A and B without question. Nonetheless, again, if we were to break out those administrative functions about cost control, improved quality, streamlining of service and delivery processes, those are probably easier to achieve under A and B. But it's hard to do. It's hard to untangle the spaghetti here.
Right.
Yeah.
That is exactly what I was doing.
Okay.
The transition, it's a more efficient